Good afternoon, and welcome to the Charles W. Hartman Memorial Lecture. I'm Donna Strum, and I have the privilege of serving as Associate Provost. One of the most enjoyable aspects of my job is to bring greetings on behalf of Chancellor Dr. Glenn Boyce, our Provost, Dr. Noel Wilkin, and the entire university administration. You'll hear more about Dean Charles Hartman from Dean Allen in just a minute or so, about his vision, his leadership, his energy, his creativity, and his charisma. Dean Hartman altered the trajectory of our school and university in a profound way. In less than a decade, he transformed our School of Pharmacy and set it on a path to greatness that we see today. Trend-setting approaches to teaching, quality graduate programs preparing students for academic and research positions, outstanding research and scholarship that has placed our school number 6 nationally for external research funding, and transformative service that impacts individuals and communities. For more than 40 years, we have honored Dean Hartman and his legacy with this distinguished lecture series. Throughout the years, we've heard from leaders in academia, government, industry, and professional organizations, including pharmaceutical CEOs, presidents of universities, an FDA commissioner, a U.S. Attorney General, U.S. senators, a governor, an author, and presidents of the American Medical Association and the American Heart Association. For me, this welcoming is extra special because I can remember attending the Hartman Lecture almost 25 years ago as a pharmacy student. And at that time, we heard from Senator Trent Lott, and he discussed national healthcare issues, cost, quality, and access to medications. And at that time, especially for the elderly, as Medicare Part D had not been passed. And I remember being inspired. I wanted to lean in, wanted to understand more about pharmaceutical policy and pharmacy service delivery. And today, my hope is that you will be inspired to make a difference for your patients. Today, we are fortunate to hear from our most distinguished speaker, Rear Admiral retired Pamela Schweitzer. Like Dean Hartman, she achieves excellence. She's a national pharmacy leader who has contributed greatly to the profession and to public service by leading initiatives to improve medication use for patients in the Indian Health Service, patients in the Medicaid, state Medicaid programs, and the Veterans Health Administration. So Rear Admiral Schweitzer, we are honored by your presence and welcome to the University of Mississippi. And for everyone else who has joined us today, welcome. Thank you.
Thank you, Donna. Well, hello, everyone. On behalf of the School of Pharmacy at the University of Mississippi, I'd like to thank you for attending the annual Charles W. Hartman Memorial Lecture. The School of Pharmacy started this lecture series in 1973 to honor the school's third dean, Charles W. Hartman. Dean Hartman's tenure was tragically cut short by an automobile accident nearly 50 years ago. Today, we remember Dean Hartman for his many accomplishments on behalf of our School of Pharmacy, pharmacy education, and the field of pharmaceutical research. Charles Hartman was born in Alabama in 1924 and served as a pharmacist mate in the U.S. Navy and Marine Corps. After his service, he received his pharmacy and master's degrees from the University of Georgia. He then earned his PhD from the University of Florida in 1956 and joined the University of Georgia's pharmacy faculty thereafter. Just 5 years later, he became Dean of the University of Mississippi School of Pharmacy and immediately set about advancing it further. He secured funds to construct Fazer Hall, which today serves as one of our main buildings on our campus. He also created our Research Institute of Pharmaceutical Sciences, now a world-renowned institute that comprises 4 thriving research centers. Dean Hartman's research interests range from drug absorption to pharmacy administration, and he was granted 8 patents throughout his life related to his numerous investigations. He also served as Vice President of the Mississippi Association for Mental Health and was a consultant to the U.S. Public Health Service. He was active in the American Pharmacists Association as well as other professional groups. Tragically, this champion of pharmacy education, pharmaceutical research, and the pharmacy profession was installed as Vice President of the American Association of Colleges of Pharmacy only 5 days before his death. Charles W. Hartman had a profound impact on the school pharmacy. We are proud to honor his legacy today and to celebrate his many contributions to our school, our profession, our university, and our state. Please join me in recognizing him. Thank you. It is now my great pleasure to introduce our guest lecturer, Rear Admiral Pamela Schweitzer. Rear Admiral Schweitzer received her bachelor's in biological sciences from California State University, Fullerton, and her Doctor of Pharmacy degree from the University of California, San Francisco School of Pharmacy, before completing an ambulatory care and administrative residency at the University of California, Irvine Medical Center. After a 29-year career in federal service, she retired in 2018 from a 4-year term as Assistant Surgeon General and the 10th Chief Pharmacy Officer of the United States Public Health Service. As the first female Chief Pharmacy Officer, she led and coordinated over 1,300 pharmacy officers in 13 agencies with the Office of the Surgeon General and the Department of Health and Human Services. Throughout her career, Rear Admiral Schweitzer served in the Indian Health Service, the Veterans Health Administration, and at the Centers for Medicare and Medicaid Services. She led the Indian Health Service's national transition from paper to electronic medical records, along with several other transformational projects. While working with Medicare and Medicaid, she helped states modernize their Medicaid eligibility and enrollment systems, drug pricing, and public health. She has been recognized for her leadership contributions, including with the American Pharmacists Association Distinguished Federal Pharmacist Award, the U.S. Public Health Service Mary Louise Anderson Leadership Award, and as the University of California San Francisco School of Pharmacy's 2015 Distinguished Alumnus of the Year. Since retiring, Rear Admiral Schweitzer continues to work on a number of health-related projects, such as increasing health access to in rural communities and improving payment models for pharmacist practitioners. She is a private pilot, a certified scuba diver, and an avid hiker, having summited Mount Kilimanjaro twice. We are very excited to hear from her today as she speaks on It Is Time, Transforming the Pharmacy Profession. Please join me in welcoming Dr. Schweitzer to the lecture.
Thank you very much. I love the hospitality here. This has been an absolutely wonderful time for me to come visit. I've had tours, I've got to meet some of the faculty, I've got to be able to meet some of the students, and it really genuinely is an honor to be able to be the speaker this year for Dean Hartman. And I did a little bit of reading about him. I actually knew about this. They invited me a couple years ago. You were super organized school, by the way. And I did a little bit of reading about him, and as I look back and I read, he's a legacy someone that you need to study and learn from, because some of the things that he's done, just being a visionary, being a doer, and some of the qualities that he had are just something that we all need to have to be able to make change. So I'm really happy to be able to be here today. And you're probably wondering why I picked It Is Time. How many of you seen this movie, The Lion King? Okay, we all have. So this applies to our profession, but in The Lion King, just as a refresher, there's a point where he's off over doing his thing over in this nice, Simba is over there doing his thing, and then the baboon comes, and they find out he's still alive, and all right, this is time. It's time for him to step up and do his part. And the same thing when I go mountain climbing, there's a time when you're sitting, you're trudging away, and all of a sudden, all right, it's time to push for the summit. So It Is Time is going to apply to everything, because all of us together, and when I say this, all of us together, I'm talking about the whole profession, academia, everything, everybody, this push right now that we need in our profession to kind of get to the level, it couldn't be a better time. And for those of you, I wish I could trace places with you right now as students, because when I see the things that I'm around right now, it's taking off. There's so much value that we provide, and we just got to get our foot in the door. And so since I retired, that's what I'm trying to do in my own little way, is trying to get in there, get in the door where I was exposed to some of the areas to be able to help our profession. So you're probably wondering where I was or where I worked. So has anybody heard of the Department of Health and Human Services at all? Have you heard of that? Coronavirus is probably where we sort of, if you hear it in the news, you've heard of Secretary Azar. He is the Secretary for the Health and Human Services. Well, if you look at the arrow there on the left-hand side, in there is the Assistant Secretary for Health. And the person in that, and I'll show his picture in a minute, his name is Admiral Brett Jawad. He's actually Dr. Brett Jawad. He's a pediatrician. And so he was over the Public Health Service. I was a Public Health Service, U.S. Public Health Service commissioned officer, and there's about 6,500 of us around all different disciplines, and I'll show you that in a minute. And in that department, the department on that left-hand side is the Surgeon General is in that department too. So you see how big HHS is. So HHS also has the FDA, HRSA, SAMHSA, Indian Health Service, CDC, all those other agencies are in there. So it's a really, really big agency, a real big department. And then I also had worked at CMS for a while, worked there for about 5 years, and that's where I sort of figured out how all this policy works and all the regulations and all the politics and statutes and everything like that. I actually was able to get exposed to all that, which is what I'm leveraging now that I'm retired. So on the right-hand side, how many people have been to Washington, D.C.? So if you go, not too far from the Capitol is where you see the HHS building. That's the one on the top on the right. And CMS, you probably don't get a chance to see that because they have it so locked up, you can't see the building, but there you saw a picture of it now. So Admiral Jawad, he's the one on the left that I told you about, and then our current Surgeon General is Dr. Jerome Adams, and both of them, they have their, anytime anybody comes into office, they're working on something that they're focused on. Admiral Jawad is from Texas. He's really focused on trying to get public health service out there. And, you know, if you think about it, trying to switch how we're looking at healthcare using prevention instead of treatment to try to lower some of the costs. So a lot of these initiatives that you hear about are actually hidden behind the scenes working on these. And it takes all the departments working together to make it work. And then on the right-hand side, the Surgeon General, he's really focused a lot on mental health, behavioral health, and the opioid epidemic. He has a brother that ended up is in jail right now just from some of that, so he sort of has a first-hand experience of that, and also building partnerships. Part of this is about if we have healthy communities and we have economically viable communities, we're going to have healthy communities, knowing that economics and health kind of go together. So he's really been trying to push some of that. And then I just put up here, this is not all the agencies, but this is some of the agencies that I had officers in, the 1,300 officers that were mentioned. So if I needed something over at SAMHSA, I'd just call, hey, so-and-so, you know, who's the person to talk to? I'm looking for this. Or if I had something at HRSA. And I still do that now. I'm leveraging all those contacts right now to try to make change, because it's not just one agency all the time. Sometimes it's 2 or 3 agencies working on that. This gives you an idea where we all are. And then I put this chart up so you get an idea. We have several disciplines that are in the public health service. So it's the highest number of officers were the nurses, and that's that top column, that 1, 2, the highest column. The next down was pharmacists. We have that many pharmacists in the commissioned officers, and they're spread out all over. Most of them are in the Bureau of Prisons, the Indian Health Service, and then we have a whole bunch in the FDA too. So for those of you that are into research, and we have them in the CDC, I would say those are the big areas there. We only had about 40 at CMS. So anyway, they're all in those areas kind of spread around, working on different departments. And the general positions that they were in, we're not filling regular positions. When they had a new project they needed to get off the ground, or when they needed a new department get going, they would bring the officers in for these new projects. So we always were assigned new projects. So I came in at CMS because the Affordable Care Act had just passed, and they needed expertise to help kind of get all the regulations and implement that. So almost all of us are coming in when there's growth going on in some of those departments. The other thing that we were involved with, all the officers, and right now they're super busy, like right now. I was in DC last week and they're like all running around, is the coronavirus. So that's got them all working. We have people scattered all over. We have the headquarters is there at HHS up on the top floor. You know, they have officers assigned there. So we're real busy with that right now. But during hurricane season, we have officers there. And they're sort of behind the scenes, but they're always there. And if you saw the infrastructure that our country has in place for these disasters, you'd be super impressed at how, in general, it's super organized. All right, and since retiring, as you heard already, I'm working on rural health, which I'll talk a little bit about in a minute. I have a couple of grandkids, and almost everything I'm doing right now is with them in mind, because a lot of the changes that we need to happen in our country, they're going to be impacted by them probably the most. And then we have a place in South Dakota. I know we have some folks that like the Wind Cave. We have a place up there. So I go back and forth between Arizona and South Dakota. And, you know, going back when it's hot in Arizona, I go to South Dakota. All right, so here it is. This is a picture. This is like what it looks like when we're going up these mountains. And what I'm going to talk about today is I'm going to talk a little bit about my career. And then I'm going to talk a little bit about transforming the profession, the next part there. So what I was going to say about, like, just the career, you don't know about this until you look back afterwards. So here I'm down my career, and I'm looking back, and what did I do? You don't really think about it until I look back. So I'm looking back, and I'm telling you these things, hoping while you're going into it, that you'll realize, oh, this is going to fit in somewhere eventually. So it's a lot of work. And going up these hills, you don't always know where you're going. I mean, you can't see the top yet, but that's what this is like going up these hills. And you kind of get in a zone, just like you are in school. You know, you get in the zone of getting up, studying, doing that zone. That's what this is like, the zone. But this is what makes a big difference. How many of you here, well, I don't want to put anybody on the spot, so I'll just say it. What ends up happening is I've never worked a day in my life. I actually have never worked a day in my life. And the reason why, I was really fortunate, because what I did is I found my passion. I found what I like to do, what I want to do, and I've kind of mixed that in. I'm able to make a living doing that. I'm able to make a difference in the world doing it. And so if you look at all these circles, it's kind of like what the world needs. Have you seen this before? What the world needs. And then in the middle there is that you find the mission. It's mission driven. So anyway, I was just really, really fortunate that I was able to find something. So I actually, every day, it's easy for me to get up and go do something because I know that I can contribute to making a difference every day, and I love what I do. My family knows that I love what I do, and they're supportive of me too. So it's a lot of work, though, and people don't see all that work behind the scenes. And I'm going to just go through a little bit of some of my career and tell you a few of the stories of things that happened, and then it ended up being, it may have been work, but it didn't feel like work at the time. So first of all, it started out, I graduated from school, and what ended up happening, and you're going to see a theme, by the way, along this way. Graduated from school, did a residency, got a great job, happy as could be, got married. My husband decided, I realized, okay, I can do this for a while. I was there probably 3 months, and then my husband said, you know what, we should go travel. Okay, so where should we go? Well, I had gone to a meeting, and I saw this beautiful display of Alaska, and so we said, let's go to Alaska. So this was, after I finished with school, okay, because you could get a job somewhere up in Alaska. So I put my name in the hat for the Public Health Service. And what ended up happening was that I was getting calls. I was waiting for Alaska to call me, and no one called. And then finally one day, someone from South Dakota called, and I hung up, and my husband goes, who's that? And I said, South Dakota, but I'm not interested. And he goes, well, why not? And he goes, the Black Hills are there. We should go there. So I called him back up, okay, I'll come. I accepted the job sight unseen. So I went there, and this is what it looked like. So in my head, I was thinking South Dakota, black hills, black coal hills, but there's actually trees there. How many people have been to South Dakota? Oh, see, look at all the people. It's like a secret, huh? So once I got there, I ended up loving it. By that time, I was a pilot. I flew all around. One quick story, as I worked there, I worked about an hour and 15 minutes away from work. And on the weekends, we just had to go in, do our work, and then we can go home. But that's like a long way to drive. So what I said is, hey, can I fly to work? And they said, sure, you can do that. So I would fly in, land at the airport, which it's just a strip. And then I'd just go out to the road, hitchhike to the hospital, do my work, and then I'd find somebody that was there working at maintenance or somewhere and just drop me back off and go home. But do you think that I loved going to work? That was so much fun. And then I would go take the long way home, fly the long way home and get back home. So I enjoyed that. I volunteered every time they needed somebody to go to some remote clinic. I said, I'll do it, because I could always fly and land on a strip nearby, to go do that. And I didn't have to go all the way into work, get the car to drive out. I could just fly straight there. So I enjoyed that a lot. So the things that I was learning along the way, when I got to the Indian Health Service there in Pine Ridge, I got there, I was a staff pharmacist filling prescriptions, and I had a clinical background because I had my residency. And one day, shortly after I got there, someone came up and said, hey, mainly because I was new, would you be interested in being the Health Promotion Disease Prevention Coordinator? I had no idea what that was. But I said, sure, I'll do it. And so that is where I really got introduced to public health. Because all of a sudden now I'm working with the local tribe, and then that expanded to the state of South Dakota. And I was able to work and learn about public health and learning to work with the community. So it wasn't with the hospital, it was with the community. And they sent me to training, so I was able to meet a lot of different people and start working. And we were working on things like hepatitis A at the time. TB, tuberculosis. We were doing things like, even with the car seats, we worked with car seats. We had several public health initiatives, and I got to help there, and I learned how to lead from behind. Lead from behind. What that means is, this is not about me telling anybody what to do. It's learning to work with the community, finding what their needs were, and help them to implement that. And I do a lot of the work, but they'd be the ones out in front. So learning to work with that community. So that was eye-opening for me, and it clicked. I got it. Later on, we started having kids, and I worked at the VA for a little bit, and I became the pharmacy director there. And I was young. I was only out of school now 2, 3, 4 years, and working with them. They sent me to a lot of training, but there was one piece here that changed me forever. And what that was is I had a young director, a hospital director, that he was a finance guy. He could get money like you would not believe. He was really good at getting money. And he wanted to make an impact in the world. And so these are great people to work for when you work for someone like this. He just says, don't break any laws, make stuff happen. And I said, hey, I'm on it. So what we did is, I couldn't have more staff, but he said, you can have all the money you want for automation. I said, all right, we'll be the first. So we had a good team of people. I got involved in automating everything. This is a long time ago. Automating everything and working with all the nursing staff, learning how to work with all the different departments to kind of get things implemented. Because it's one thing about just getting a machine in there and having it, but it's getting everybody to use it correctly. You know what I'm talking about. So anyway, I did that. So that was actually wonderful. I learned about budgets. I learned about financing. I learned how to sell. I could sell, after a while, I shouldn't say this. After a while, you learn how to present, get all your paperwork together, and to present an initiative to someone high up and get them to approve it. Like practice for your dean here, you go and, practice how to sell them an idea. So I learned how to do that, how to package it with numbers and data to be able to sell. So I learned all that at the VA. So then I went back into the Indian Health Service, and now this is where I actually stepped down in mine. It seems like it's a step down, but to me it was the best thing I could have ever done. What I did is I needed to get closer to Arizona, or to my family, so we went back to Arizona. But there I went down from a pharmacy director doing everything to a staff position. But I had 2 little children, and they were awesome little children, and it was about spending time with my family. So we had the best time ever. We had lots of friends, we had potlucks and dinners, and the kids played with all the kids. Did sports, we did camping. So I had a couple of years of that where we just play. My husband was happy, everybody was happy. But if I had kept working at that other pace, it would have been tough with the kids so little. So then I went on and I became director again at this Indian reservation. It was a tribally run, which is a little bit different than, it's different than run by the federal government. So the tribe says, we don't want the government. We want to run it ourselves. Give us the money. But we need some help a little bit with the federal government to get off the ground. So my role was going in, and if I did a good job, I could work myself out of a job. That's the attitude that we had when we go in there. And just help them get off the ground. And I had to change, it was a change of culture for everybody. So we had to get that change of culture, and it was listening to what the community wanted versus what we thought they should be doing. And so I was there when changing all of that. I had learned a lot about strategic planning during my VA years, and I brought that in. And this was critical. The board of directors asked me after they saw what we did with our pharmacy department, they said, could you go do this with all the other departments? So what I had done is every department, I went around and did a strategic plan from them. And do you think I learned every other department? I learned them cold. I learned the departments I didn't like, which were like, at the time, acquisition. They always told me, you can't buy this, you have to do this. But I learned how they all worked. Some of the departments that we would have little battles with, I learned how to work. I saw the world from their view, I guess is what I'm saying. So anyway, that changed everything, and I was able to really, over the rest of my career, that came in handy. And probably one of the things, and for those of you going into patient care, this was probably one of the best lessons that I learned. And one of the things, we were in this transformation, trying to change the employees' attitude towards the community. And one of the things was they went and rehired new doctors, rehired new staff. I was one of the new ones they brought in too. And we asked the tribe, how are we doing now? We've changed, we made all these changes. You asked us to, how are we doing? And they would keep on saying, nope, you don't have it. Nope, you don't have it. And our outcomes were better, our wait times were down, everything on paper looked better. But what happened is one of the meetings, one of the local people, one of the local elders that were there stood up, and in her native language, she talked for quite a long time. And when she sat down, everybody was silent. She said what needed to be said, and this is really what it was. Is what they were looking for is people that were caring, compassionate. They wanted them to be part of our community. That's why I'm kind of into this rural thing, you guys. Be part of the community. They wanted someone that cared about them and not just, you're done with your visit, check box, move on. And so that was the main thing. It shouldn't be all business. Don't talk down to them. They wanted someone that they could really respect. So we changed how we did everything. And once that happened, it clicked. And we changed how we approached, even patient care. Treat everybody like they're our mother. And then I jumped, I'll kind of just fast forward some of this. I got involved with a lot of national programs after this, and this is sort of where I got involved at the national level doing a lot of transformation projects. There were several of them, just national. A lot of them are they take a long time, 5 years or whatever, but learning to work with different people and different interests and different disciplines. But all these other things had kind of prepped me for this. So I think it was mentioned in my introduction, going from paper to electronic medical records. It seems like an easy project, but when you're doing it for 150, 200 facilities, it's a big project. So I got to be the transformation lead for that. We did the mail out. So I'm going to get to this other one here. You're going to kill me for this right here. You're going to kill me for this one. So what happened was, as I was younger or earlier in my career, I saw the pharmacists just filling prescriptions. It wasn't me. They all complaining about it. There's so many prescriptions. I don't have time. I'm so busy. I can't do these other clinical activities. I've heard that a zillion times. So the thing is, what do? We've got to get rid of the filling. How do we get rid of the filling? So remember, I had already done automation. Well, why don't we do some of that? Absolutely, no way. We're not taking this. We don't want to give this up. This is like we can't automate. So, I heard all this. So anyway, it took a little bit of time, over time, to kind of plant those seeds. And I needed just a couple of programs to try it, just to see if we can free up ourselves and do it the right way so that as their time got freed up, we can fit them into the workflow and have them work with the medical staff more. Now, I had already done that with the VA, and for those of you that are not aware, the VA sends about 80% of their prescriptions off to be filled through automation. Now, the front end, the folks that are doing all the talking to the patient are still the pharmacists. It's just instead of going to the pharmacy to fill, it goes to the mail out to be filled. And so we wanted to do that same thing in the Indian Health Service. So we did the same thing. And I heard every excuse you can possibly imagine. That number one, that our CEOs they're going to take away our positions if we do that. The patients don't want that. There's no way that all the patient, and they didn't want that. The pharmacist didn't want that. Okay, that's fine. So we'll just need a couple sites. So we ended up, to make a long story short, just to get to the end, we did find a few sites and had them try it, work out all the kinks to everything, and get it moving. And now, to this day, I had only expected, the bar I had set was 10%. If you can just get 10% of your workload, then you take that pharmacist and put them into the clinic or provide more clinical services, and they're up to like 50% now. So, and then of course the pharmacists are spread around. Until we got rid of that workload, we couldn't do the clinical work that you're trained for. And that's the moral to this story, is that the prescriptions still need to be done. It's never going to go away 100%. It will never go away. You always need to have the ability to fill prescriptions. But the clinical part, getting your foot in the door, working with the medical staff, if you do it slow enough and everybody gets used to it, nobody lost positions. If anything, they gained positions when that happened. Once they saw the value, holy cow, we should have had a pharmacist a long time ago. You saw that the FTEs in the clinical side went way up. So I know that it seems like a scary thing to do, but this is one of the things, trying to talk the pharmacies, realizing if you do this right, we can do this so you don't lose FTEs. You always need the filling to be there, but we've got to get rid of some of our filling so we can have time to do this clinical work. And then once that value is there, then it increases. We get a lot more pharmacists. And this is not in one facility. This is nationwide, this all happened. And then when I got to DC, I think I told you already, I got there really for the Affordable Care Act. And I did I did work with the information systems. I also worked in the provider enrollment screening systems. So I know how they're all designed, and we put the standards together for how to implement those. So that back end, how to get the payment done, that was the part, the light turned on. And I realized, that's why we've got to there's a bunch of other policies that need to be changed so we can get in those systems so the payment can be made. So at least I saw the whole picture from there. And I also got to know the people doing all the models and all the innovation studies. And so that's kind of what I'm working on right now, is trying to get some models focused on rural pharmacy right now to get those funded so that we can do these models and get the data from a little bit different perspective so CMS will know. In my other role, it's kind of like dual role, overseeing all the 1,300 officers working with, and we had other projects that we were working on, tobacco cessation, pretty much similar right along with the Surgeon General was doing. So we would just follow like his lead on the priorities that we would do there. Did a lot of leadership, and having people step up. We have a lot of deployments out there, and we haven't been able to have people step up for that. And then I kind of transition now a little bit to what's going on right now. This disruption is not going away. None of this is going away. This is even more of it. And so as I'm getting in this, I've remember I'm in the IT world, I at least have been around all these people that they go, we need to pull pharmacy in here. This is like, a pharmacist needs to get in here. That's why there's so many jobs out there. I just had, and I was telling the students this morning, a friend of mine, he's a cardiologist, and what he did is he has a patch that monitors patients taking their medicine. So Parkinson drugs, for instance, you can tell by when you have this patch on, and it's been FDA approved, it just got approved. When you have patients that have Parkinson drugs, you can tell when the drug's starting to work remotely, just how they walk. The same thing with pain management. You can tell how they walk, that their pain is being controlled. So, like, that's just an example, and all of this really needs to be managed. All these chronic diseases that we have out there, there's tools right now that can monitor remotely or just in person when you get to know the patient. These tools that can be used out there, and it's like this whole other world out there. How many of you all have like a smartphone? The world, you're so good at this. My kids are probably like you. They're like so good with all this technology and doing everything. It's a whole other world right now. So we have telepharmacy. There's pharmacogenomics. Doing the drone, and you guys have this cool little computer. What is it? What do you call it? Robots. Little robots running around. See, you're already there. This is like so great. Anyway, having all these robots around here. I put this other picture up here too because this is physicians. You see them dispensing medications too. Is that good or bad, you think? Is that okay? I don't know. What do you think about that? Do you think that's okay? Well, we're prescribing. What do you think that? Anyway, part of this is looking at where they're coming from and looking at, we need to figure out how to work together. Now, the good news is all of you are trained with the physicians. Your third and fourth year, right? You're working together. And so the goal is when you come out of school, you'll continue to work together too. This is some more technology here. Almost everything there's a lot of remote tools out there. If you saw the number of inventions, when I go over to the FDA, there's a whole department called devices of this really cool technology. And do you have a technology department here? I was going to ask you. Do you do that a little bit already? A little bit of technology? Okay, well, you're going to just see this whole world of it coming out, monitoring patients and managing all of them. So let's just talk about some of the challenges that we have here. One of them is the relationships with the providers is changing. You're trained with them right now, or you will be trained with them in the next few years. But part of what's driven this is the finances. So I'm going to kind of flip this around. If you were a physician and you get paid for a service, why would you want someone else to come take over for you? You probably don't want to. But as it gets changed, as the payment changes where they're rewarded for, like they're paid a set amount of money, it's not just volume, it's more like the value. If they want a good outcome, you need a pharmacist. There's so much care right now that's fragmented. Fragmented means you get care sometimes over here, sometimes over there, sometimes over here. And then what ends up happening is the patient, it's like they're all confused. And especially when there's medications and they have a lot of them, it's really hard. They need someone to sort all that out. There's a major value there to add that, because how long does that take for an expert pharmacist to sit down and sort out when someone's been having their care everywhere? You can't do it in 5 minutes. It takes a little bit of time to sort it out, to fix everything, so it takes a little bit of time to do all that. So there's a big value there. The other area is public health. So I should probably maybe I can ask you to shout out, what's public health to you? What would be an example of public health? Okay, immunizations, that's one. What's another one? Say again?
Smoking cessation.
Smoking, exactly. Smoking cessation. Anything else? So anyway, well, you be watching for, this is a space right now this is a space right now that this is something that pharmacy can easily own. We're already in it right now. We're already in it. I would say tobacco cessation, immunizations is pretty easy in there. What about the naloxone? Is that kind of public health? Opioids, is that kind of public health? So start thinking about what public health is. Any of these things where you're seeing the patient all the time and you can make an impact in your state, in your community, that you can help the patients in your community. What about diabetes prevention? Do you think that would fit in there too? That's public health too. Obesity, eating well, improving your health. There's programs out there right now. These are all resources right now that are out there that pharmacists are getting involved in. There's a whole big list of them. Anyway, so this is another area that's just wide open, and you're going to see payment models starting to change to reward that. So they're going to need people to connect to patients to be able to do that. Be that caring, connecting to patients to be able to drive them to change what they're doing. The role of pharmacy technicians, I don't think we have any in there, but pharmacy technicians are doing more and more and more. They can take over a lot of the technology and manage all of that for the filling of the prescriptions. And then you have precision medicine. Have you been exposed to that? I know you have because I chatted with precision medicine, the pharmacogenomics, all that telemedicine. Looking at data, population health, we can look at data. Coronavirus. Do you think right now that they're looking at they're looking at data all over the place right now, looking at data, honing in. There is so much data out there. You know how like the advertisers, you see an advertisement, you wonder why you get like a message on something. You may have filled something somewhere out. They can do all that with health data too. They can narrow down exactly. They have so much data, they know exactly what you're going to do before you do it. And then also another area for those of you that are interested in leadership is there is so much that you can do to get get into the C-suite. We need a lot more people in the C-suite to help influence the changes, let people know about pharmacy. I'll give you an example. When I was at CMS, so here I am at CMS, and I'm a pharmacist, and people were always emailing me and saying, Pam, can you tell us a little, can you find out about this here, this happened here, we had this happen, oh yeah, that's not right, let me go find out. So I would walk down the hall and I'd figure out where to go to be able to make that change, to see what needed to happen. And what ended up happening, they had no idea that the pharmacist was even practicing clinical. So I would hear lots of stories about, oh yeah, I had this is my little story about the pharmacist and I got the wrong medication, or this is the story where I went and I never see the pharmacist. So I'd hear all of that and I'm like, okay, we have a long way to go with this group. And a lot of it is some of them didn't get seen a lot, or they took their family member there a lot. So we still are going to always have to have education, but right now is the time, because what's lined up right now is we've never had so much of a push by all the different organizations, all the pharmacy schools. Everybody is pushing right now. There's just a lot of movement right now. So we need more people understanding healthcare finance too. Do you know what that means? So understanding how the health plans are organized. So to explain it a little bit really simple is that right now when you get a prescription filled, that's the PBM side of the house. That's the prescription, and you get a prescription, the cost of the drug plus a dispensing fee. The medical side of the house is where our value really is, because what we can do is if we're providing a service, we're keeping somebody out of the hospital, out of the emergency room, and who benefits the health plan. So we've got to kind of separate that out a little bit. So along the way, I'll just tell you the skills that will help you along the way, just learning how to think strategically. And so where do you get all that information? How do you learn that? You learn by kind of watching. Watch how people make decisions, observe all that, reading books, we'll do all this. And this is what Dean Hartman had. He had that skill down. He was a strategic thinker, going around, and you do a lot of seed planting. I know your dean does a lot of seed planting around, just, trying to get ideas out there. And then focusing on the mission. I would say my whole career, that's probably the best advice I can give to anybody. Wherever you work, you stay focused on the mission. I didn't get sidetracked from that. I learned that, I had that drilled into me from day one, is focusing on whatever that mission is. And then every decision is easy. Should I get involved with this project or this project? Well, does it go along with the mission? And I can make changes there. The other thing is filling in gaps. My whole career was really made filling in the gaps. Nobody wanted to do this. So, okay, it's important to the mission, I'll do it. So I stepped up a lot of times when it wasn't the fun thing or pretty thing to do, because once you learn how to drive some of that change, it's just the same thing over and over again. So that's why I actually am in rural health. So I'll tell you a little bit about that. I became interested in it because remember you saw I'm in South Dakota, and I saw after I retired, there was a bipartisan meeting focused on rural health strategy. And I go, oh, that seems pretty interesting. So when I was back in DC, I was there for another reason, and I went to the meeting. And as I was listening there was only 50 people in the room, and they had some of the different congressmen talking about it, about, rural health, some of the challenges that they had. And they were from, I remember someone from Texas, maybe Iowa, they're from a few different states talking about what was going on in their states. And then afterwards, then they said they opened it up for questions. And so one of the physician groups stood up and said, I'm from the AMA and da-da-da, they had a question. And I said, well, I'm standing up for pharmacy. I didn't know who was there from pharmacy because I didn't know everybody. I stood up and I just asked them a question about pharmacy, and of course, then they had a good discussion, so I was happy about that. And then the nurse practitioner stood up, and then the PA stood up. And then afterwards, I realized there wasn't a pharmacist in the room. I just happened to be there, but I wasn't representing any pharmacy organization. And so I went around, and I've been visiting with all the pharmacy organizations since then. So this is a little hole. I call it a hole. It wasn't covered already. That's why I jumped into it. And that's why I'm working on rural health right now. But now they're all helping. I've got all the pharmacy organizations. We have the schools of pharmacy helping. If we hadn't have got this all organized, and now there's going to be some momentum. So I'm excited for anybody that graduates and goes into rural health, because you're seeing the very beginning of this right now, and some of the changes that are coming about right now are going to be just the efforts that the whole profession is working on together. So the other skill is being creative, thinking out of the box. I was talking earlier to students, and I think one of the things that I was always lucky, I always worked for great bosses. I always worked for people that believed in me, that let me take chances. And you fail. I didn't do it right, or I should have done it different, but you learn and they let you do it again. But being creative, thinking out of the box, being entrepreneurial, I do a lot of reading, so this is constant learning. I had to read. I never learned any of this stuff at school. I never took a class in learning how to do the IT stuff, but you would have thought I did it. I was an IT person. I learned how to do all the e-prescribing. I didn't take a class in it. You learn right now, you're learning how to learn. And you know how like when you sit down and you're studying for an exam and you just learn and you go until it clicks? Somebody nod. It clicks? It clicks? So that's the same thing. Like you learn something brand new and you read the book and you're like, okay, I'm going to read this, okay, and you ask questions, you bounce ideas off of people, and then you got it down. So almost everything I've learned in this last 3/4 of my career has really been just reading, learning, figuring out, bouncing it by people that know it already, and then kind of getting that down. Because a lot of this is not a book to tell you how to do everything. It's so new. Things are so new. Maintaining partnerships and relationships. I can tell you, I still know people back from my college days. All of you, you're working together. You're going to get scattered and go different places. Keep in touch with each other, because you never know where you're going to end up. We had a big smoking tobacco. Have you guys heard of RX for Change? RX for Change. Okay, so that's my roommate that does that. My roommate in pharmacy school. That's how small of a world this all is. My roommate in pharmacy school. So it's Robin Corelli and then her friend Karen Husband. I've become good friends with them. But I knew them back in pharmacy school days. So these relationships really pay off over time. And then I should probably and staying current with it. I was always involved in the pharmacy organizations, doesn't matter which one. I didn't have a lot of money early on, so I'd kind of alternate, like I'd go to like every third or fourth year, you know, I would kind of rotate because it's a lot of money when you're, I'm a member of all of them now, but back then I remember rotating because I didn't have enough money to be in all of them at once. But what I should do right now is tell you, I didn't talk a lot about the public health service in uniform, but if anybody is even remotely interested in just getting out of the state, trying something new for a few years, and you can come back home. It's not a forever thing. You don't have to do it forever, but just get that experience. This couldn't be a better time right now. We have closed all the positions up to now, and you have to it's like you have to know someone to get in, and they just opened them up. So they're opened up wide. They're trying to hire right now in the United States Public Health Service. So if you're interested, see me afterwards, or I can send you the link. Maybe you can get it out to students that are interested. And what it is you go to where the needs are. Remember all those agencies you saw there. If you have an expertise in something, you know, this is the time to do it. So isn't that exciting to know? I know. So they haven't opened. It's been at least 10 years since they've opened it up. Up until now, it's just been people that you know somebody and, you know, kind of go through some hoops to get them in. And here. So anyway, this is for all of you, because you're going to be taking the profession to a whole other level with all this technology, with the transformation of all of how pharmacy is changing right now. It's going to be all about change. So I hope you go somewhere where you can test out and try some of these new ways of doing things, because there's no one right way to do it. There's multiple ways to do that. And that's what these models, what I've sold everybody when I tell them, we can't just say there's one way to do it. Because in our rural communities in our country, we have to be flexible, we have to be adaptable, we have to meet the needs of the community, and we need to be able to have the flexibility to do all these different models. So isn't this exciting? A little bit, politics are out there too. And then finally, I haven't talked to you, you heard a little bit, I was on top of Mount Kilimanjaro. So when you're hiking up, and I'll just kind of finish here before we open up for questions. When you're hiking up, so this is what's going on mentally. So you're hiking up the mountain, and it's nighttime, and the goal is to get to the top by sunrise. So it's about 16,000 feet you start out at. You have to go to 19 at the top. So you're going out, and you're step after step, and every time you stop, because it's dark, you look up, and all you do is see light, or maybe a few lights ahead, and it's like, oh, so far to go. So you keep going on, you stop. I haven't even moved. You know, you're thinking you're not even moved, so forget it. I'm just looking down, taking step by step, and you keep going, keep going, keep going, keep going, keep going. And then finally you realize, oh, I'm at the top, and then you turn around, and that's the view. Isn't that like awesome? So that's what we're going to have. This is going to be awesome for all of us. And we're already there now. When I make it sound like you're going to get there, there's pockets of it all around the country right now that are going on. And I know I'm going to be following up with a few folks here, because we're going to help get it move a little bit quicker. And that's what I'm trying to do, is work with all the states and help them move it a little bit quicker. So, am I okay on time? Okay, so anyway, I guess that's my last slide there. Do you have any questions? One question. So I have a son, my son and daughter, they're grown up now. My son's a nurse, and he loves pharmacists. I'm so happy. And our daughter went into, she goes, hey, would you guys like to go into pharmacy like me? No, Mom, we don't want anything to do with what you're doing. Okay. My son went into nursing, so that's kind of, it's not pharmacy, but it's healthcare. And our daughter went into public health. She's like, it's more social. It's a different kind of, it's not public health like medical. It's more like what's going on in community, how to get communities, together. But it's all public health, and she collects data from data, and they put out papers. So she's published several papers. Isn't that amazing? I know. should probably take a picture of what it looks like with all your white coats here too, by the way.
When you mentioned about going out of state for public health services, what sort of positions would these like graduating pharmacists be working? Would it be kind of similar to what you did?
Everybody heard the question. So, yeah, what it is at first is the same thing. You're just going, the entry position would probably be going in right out of school. You'd be doing whatever needed to be done in the pharmacy. It would be in the pharmacy department. So it might be filling prescriptions, but it could be, a lot of these programs now, they have clinical programs. So they kind of, you bounce around everywhere to get the lay of the land for each of the departments. And then they usually will ask you, are you ready to go into the clinic? And I know the folks that I know, no, not yet. They'll send you to training and everything. When you're ready, they'll get you rotating in clinic. So that's what ends up happening. So it depends on the facility you go to. Some of them are really clinical, but what they'll do is they'll have a lot of projects that they have that they're trying to keep going. So it might be running the residency program, or it could be working on a specific project with a physician group. So you'll have all those side projects besides whatever they do in the pharmacy. They're all a little bit different.
Good time for one more?
Hi, my name is Tia Holloway. My question is, what services or programs would you say or could you recommend to us that helps you get to the next step in your transition every time?
So the question was, what services did I learn? You know what it was, is being curious. I'm going to just say it's more of a being curious, trying to learn and asking a lot of questions. Just trying to be curious about how something worked. What makes it work together. Watching the people, how they interact with each other. I didn't necessarily get training, except for I had a ton of leadership training right early on. Like right when I first got into VA, when they put me in that supervisor position, they sent me to a lot of training. So I actually had a ton of it. Learning how to run meetings, learning how to do a lot of it's managerial work, but learning what makes people tick, some of that, getting some of that training. So, but otherwise, preparing me for the next, what actually happened is I never really applied for jobs. Once you get settled, you never apply for jobs. People come to you and say, hey, could you help with this? Or if I saw something I wanted, I'd say, hey, if you ever need somebody to help with this, I'll do it. I'll help you. And so you sort of plant a seed with them, and they come back at you later on. That's how I got at CMS. I just said, hey, if you need any help, let me know. I didn't apply for a job. So I don't think I really actually, except for that first job, I really never applied for a job after that. People come to you and they look for you.
Well, please join me in thanking Dr. Schweitzer for a great... We are concluded. We are adjourned.